Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Professor Daniel Salmon, Director of the Institute for Vaccine Safety at Johns Hopkins. They discuss what scientists may learn about a new COVID-19 vaccine after it is made available to millions of people. Back in 2009, Dr. Salmon helped to lead federal efforts to learn about the H1N1 vaccine after it was widely used. Let's listen.
Dan Salmon, thanks so much for joining me.
Thanks for having me today.
So today I want to talk about vaccine safety. We're hearing a lot about effectiveness of potential vaccines, but I want to know more about the process where we determine how safe these vaccines are. So I guess I want to start with, I know these are going through rigorous clinical trials, but what can you learn from a clinical trial and what don't you learn from a clinical trial?
Yeah, so clinical trials are really the gold standard. What's fantastic about them is that you randomize people into either getting the vaccine or not, and that everything is blinded. The person doesn't know whether they got the vaccine or not, and the people running the studies don't know that either. So that randomization and blinding really, really helps you draw valid conclusions from the data. And you start with small trials, phase 1, and as you learn more, especially about safety, but also about immune response, you do larger trials. By the time you get to phase 3 trials, and for COVID vaccines, they're pretty large. You really learn a lot from them. And you have a really good indication that the benefits outweigh the risks for the population studied. And that's the process we're going through now. And ultimately, these results will go to FDA and their advisory committee, the Vaccines and Related Biologic Products Advisory Committee, where all those data are reviewed by external scientists. And that's done in a public way. It's done open to the public, so other scientists and clinicians in the public can see that. And that's the gold standard. That's the process we use to develop and approve vaccines. But even after you make it through clinical trials and a vaccine is approved for use, there's still things you don't know. There are things that can happen that are uncommon or happen in subpopulations that are either not adequately studied or excluded from the trials. And then you continue to look at the safety of the vaccines once they're rolled out largely. And it's that post-licensure or post-rollout use safety assessment, which really helps you make sure that the vaccines are, in fact, very safe.
And how do we find out whether there are problems afterwards?
Well, there's a variety of ways. You have passive surveillance systems, which allow anybody to report anything. The one in the US is called the Vaccine Adverse Event Reporting System. And the public can make reports, clinicians can make reports, and they're useful for identifying problems you didn't anticipate. It can ask questions, but it can't answer them for scientific reasons. There's a new system for COVID vaccines that CDC is rolling out where it's basically texting reports from early vaccinees. And again, that can be useful for picking up something you didn't expect. But it can't answer questions. And to answer questions, we turn to large healthcare databases that keep track of who got what vaccine and what happens to them afterwards. They're not set up for research purposes. They're set up as a part of healthcare systems, but they're used to answer vaccine safety questions that might arise once a vaccine is rolled out.
This will be a huge undertaking. I mean, we're talking about hundreds of millions of people will be getting this vaccine. And the question is, how do you tease out what is just something that was going to happen to someone anyway versus something that is the result of getting this new vaccination?
That's a great question, right? There's always the potential for a real adverse reaction. And in the case of COVID vaccines, these are new technologies, so we have to be particularly careful and prudent. And if there is a real adverse reaction, we have to figure that out quickly. We need to figure out how common it is, and if it's more common in some populations than others, and if possible, the biological mechanism for why that happens. And then depending on how frequent it is, that might change vaccine recommendations. I mean, it could even change the authorization to use the vaccine depending on how serious and how common it is. But vaccine programs are prone to coincidental adverse events derailing them, especially mass vaccination programs where you vaccinate a lot of people in a short amount of time. So, for example, if we vaccinate 10 million people over 65, we're going to have heart attacks and strokes that occur in the same day as the vaccine just by chance alone. Because if you take 10 million people today over 65, lots of them will have heart attacks and strokes. So the key there is to really quickly and rigorously and with credibility separate real adverse reactions from coincidental adverse events that happened around the time of vaccination, but not because of the vaccine. So this is why your question is so good, and I haven't even answered it yet. So how do we do that? Well, we look at these large healthcare databases, and we typically calculate the background rate of adverse events in those databases prior to rolling out the vaccine. So, for example, the Vaccine Safety Data Link is one such system. So for heart attacks and strokes, they'll calculate the rate of heart attacks and strokes in their population prior to rolling out the vaccine. And then when we start to see, for example, heart attacks after vaccination, we can compare that to the rate that would have occurred anyway.
As we said, there will be people who have heart attacks and strokes after they're vaccinated. And there's also there's people in this country who are very hesitant about getting vaccinated. How are we going to sort of reassure people who are prone to this skepticism that there's not a major problem?
Yeah, it's a real challenge. I mean, in 2019, the World Health Organization declared vaccine hesitancy a top 10 global health threat. And we were seeing reoccurring outbreaks of measles because there were communities where people were refusing vaccines. In fact, in 2019, we almost lost our measles elimination status in the US because of so many outbreaks. We see vaccine coverage for diseases like HPV are quite poor, largely around hesitancy. Influenza vaccine coverage every year is far lower than it should be. And, a part of it is people are worried about the safety of vaccines. And part of it is they may not perceive the risk of disease to be as bad as it really is. So this is the climate where we are seeing COVID evolve. And as this pandemic has evolved, there's a huge mix in how the public sees the government response. There are a substantial portion of the population that think COVID is not a big deal, that scientists and public health are making a bigger deal out of it than it really is. And we see problems with things like compliance with wearing masks, and even people questioning the safety and effectiveness of mask wearing. At the same time, there's a large segment of the population that feels like the government response has been totally inadequate, and that politics have undermined science, and the credibility of organizations, public health authorities like CDC and FDA have really gone down. So, on all of these areas, it makes it very, very challenging. And we see that about half the population says they don't intend to get a COVID vaccine if made available free of charge, at least not right away. And that's really a problem because at the end of the day, vaccines don't save lives, vaccinations save lives. And we could have very safe and very effective vaccines. But if most of the population doesn't want those vaccines, either because they don't think COVID's a big deal or they're worried about the safety of the vaccine, then our greatest tool will be ineffective.
So during the 2009 H1N1 outbreak, you were involved in overseeing some of the safety and effectiveness work on that vaccine. Can you tell us a little bit about how that worked and what lessons we need to take into account today?
Yeah, I'm happy to. At the time, I was the director of vaccine safety at the National Vaccine Program Office. So I was responsible for overseeing the safety monitoring of the 2009 H1N1 vaccines. And, in that situation, it really wasn't a new vaccine. It was a strain change. In fact, if H1N1 had emerged 6 months earlier, it just would have been a part of our seasonal flu vaccine. And we know a lot about the safety of flu vaccines. So there was always some potential for a real adverse reaction we hadn't anticipated. But we had a lot of confidence that the vaccines were very safe. What we were worried about more so was these coincidental adverse reactions and derailing the program. So what did we do? Well, firstly, we got all hands on deck. We had clear leadership within the Department of Health and Human Services, from the Secretary to the Assistant Secretary for Health and the Assistant Secretary for Preparedness and Response. And they really empowered me in my office to do our job. And so we had clear leadership, which is a really important piece. We took all of these healthcare databases that we had the capacity to use, and that was CDC's Vaccine Safety Data Link, data from Veterans Affairs, Department of Defense, Indian Health Service, Center for Medicaid Services, and we brought them all together. We also developed a new system called PRISM, and we did this with Harvard Pilgrim, where we took 10 state immunization registries and linked them to 4 large health insurance companies. And ultimately, this gave us a tremendous amount of data. I should just point out that all of these data are anonymous and de-identified. So what we got was counts. We got things like there was a man who was 50 to 65 that had a heart attack 4 days after the vaccine. No way to identify who that was. And we brought it all together. We brought it together internally. We had a federal immunization safety task force chaired by the Assistant Secretary for Health and Preparedness and Response, and had high-level scientific leadership from NIH, FDA, CDC, Departments of Defense, Veterans Affairs, Indian Health Services. So we had an internal coordination. And then we had an external advisory group. It was external to the rest of the immunization program. It was called the H1N1 Vaccine Safety Risk Assessment Working Group. It was a part of our National Vaccine Advisory Committee. And these were independent experts that had no conflicts of interest in terms of their funding and their research, but they were also independent from the program promoting the vaccine. And every 2 weeks, the scientists within the government shared data, and then we shared these data with this advisory committee. And once a month, they made public reports, so there was transparency. So we had a very rigorous system. We had a lot of data. And we also set it up in a way that it would be credible, so that if we saw a problem and we assessed the data and came to a conclusion, that the public would believe it.
And I guess these are lessons that we can really take into account as we move forward in assessing a COVID vaccine.
Well, I hope that it is.
You mentioned that H1N1 was just really a little tweak to the seasonal flu vaccine, and so you didn't see a lot of adverse reactions. Is there a possibility with a brand new vaccine that we'll see more?
So there's always that possibility, right? That whenever you do something new, you need to be particularly careful and open to the possibility of something you didn't anticipate.
I mean, I want everyone to be transparent with me. I want to know if I should be lining up early, although I'm not in a high-risk group, but if I should be lining up as early as I can to get this vaccine.
Transparency is a very important part of trust. So what I hear you saying is, I want to trust that this is what's right for me and my family. And if the process is transparent, then you're more likely to trust it.
Absolutely. Dan Salmon, thank you so much for joining me.
It's a pleasure. Thank you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.